This week on the BackTable podcast.
So people that say, I do partition dosimetry, the next question I ask is, okay, cool, what software do you use? And, well, I don't have any. And I was like, well,
then you're not doing
You're not really doing it. You're guessing. And look, in all fairness, I just want us to be honest when we're talking about how we do things. And I think it's important that you have to say, you might be, in quotes, doing partition dosimetry, but you're really kind of guessing. And even then, MAA, you're still guessing too, right? So there are some inaccuracies on the pre-treatment side of things when you're doing partition and voxel-based, but there's more complexity with calculating those things. So MIRD is the most simple form of dosimetry. I recognize that there will be variances in flow. The majority of my practice is heavy rad-seg. Even in the metastatic world, I still rely on it because I think those variables, I'm okay to account for those variables within the rad-seg realm.
This is Dosimetry University, Part 2.
All right, lung shunt. Let's touch on lung shunt. How are you calculating lung shunt post-mapping?
Post-mapping, so we do planar.
You do planar, okay.
We do planar, and we also do SPECT CT, right? So we get planar acquisitions, and we also do a SPECT CT. You know, we were talking about MIM being wonderful. MIM can the AI associated with MIM can do your lung counts and your liver counts via SPECT. So actually our nuke med team, our nuke med techs will draw ROIs for lungs and liver, and as well as a background estimate, and then they'll calculate our counts on planar imaging. By and large, that is good enough, right? What you'll learn is if you start drawing these on your own, slight little tweaks in volume can change lung shunts a fair amount. And the difference in lung dose going from 3% to 6% or vice versa is dramatic. That's half of the lung dose that you receive. And so I think that sometimes in a rad-seg where my activity that I'm going to deliver to the tumor or to that perfused territory is very low.
Yeah, totally.
I don't necessarily
prescribed activity.
Yeah,
right?
Prescribed activity. When the prescribed activity is very low, I'm not really worried about what the total lung dose is or the lifetime lung dose is going to be, because it's going to be close to 3 gray at best. So I'm not going to go fight to redraw it. But if I'm doing a larger volume delivery with a much higher prescribed activity, that lung dose is going to be that it will matter, and it'll matter down the road. So you have to pay attention to how you calculate that. So for us, planar, Nima, what do you do?
So we do both planar and SPECT in terms of the type of images we acquire after the mapping, after the MAA. We use planar as a default for our lung dose. When the planar is elevated, the lung shunt is above 10%, we actually recalculate it using SPECT, because one of our own publications and a couple of others that have shown that when the lung shunt fraction is higher, the discrepancy between SPECT lung shunt fraction is higher on the planar, there is a significantly more discrepant value calculated for the lung shunt fraction on SPECT CT versus planar, and that can make a difference in terms of whether a patient is an eligible candidate for treatment or not, because of all the inaccuracies of doing the ROIs on the planar.
I'll take it one step further. For me in my practice, everybody gets a SPECT CT lung shunt. That's how I dose. That's just what I do. You know, even if the planar is 7%, I still do it. Now, I will say if I get like 1% on the SPECT CT lung shunt, I don't know that I'm going to use 1% necessarily. I'll give it a couple extra percent just to,
to be on the safe side.
Yeah. And a lot of the old radiation-induced lung injury data is based on planar, correct?
Yes.
As well.
In fact, everything that has been published to date is based on planar, which is a big problem so the issue with planar is not just not just a fraction, the volume of the lung. We just assume a 1 kilogram mass of the lung, whereas if you do the SPECT CT, you actually calculate the actual volume of the lung. And as both of you know, there's a significant discrepancy between the lung volume and, in effect, the mass between a female and a male. And the height of the patient, a lot of different factors goes into it, you know?
I think in the terms of, maybe not everybody has SPECT CT readily available or has, so MIM probably does your SPECT CT, or do you draw your lung.
So there's an auto contouring feature. I usually have to clean it up a little bit. So you spend a few minutes doing that.
But not everybody is going to have that kind of time and capability. So I think,
or have access to the software platform.
And so I think planar sometimes is the best you can do. There's different ways to do planar, right? I think it's called geographic mean, where you do anterior and posterior, and it's an equation. We normally just draw it off the anterior. But I think it matters in this. You have to understand when it matters and when it doesn't matter, or when it's significant and when it's not significant. And you bring up great points about the differences in males and females and the difference in how much activity you're going to use. But not everybody has access to software to do these kind of things. When you're going to look at counts to the degree that, and we'll probably need to talk about this when we talk about partition dosimetry, whenever we decide to talk about it.
That's coming next, I promise.
Whenever we decide to talk about it. But software is critical for those kind of calculations.
I think to make it easy, kind of like, again, thinking about resources in different settings, I think if it is a low lung shunt fraction in a segmental, planar is good enough. It's only when you want to do low bar and it's a high lung shunt fraction, that 1% to 2% difference between planar and SPECT can make a significant difference. That is when you should ask if you don't have the software, even ask your nuclear medicine colleagues to actually recalculate the lung shunt on a SPECT.
The other thing I'll point out is if you don't have a breath hold acquisition, right? And it was one of my former co-residents, Doug Murray, who's in the Northwest, that turned me onto this. If you don't have a breath hold SPECT CT, I will actually contour my liver. I'll cheat a little bit into the lung to grab some of that activity that was actually in the liver, and then just misregister it in the bottom of the lung, and then bring that back into the liver to not affect my calculation. I do that commonly. I don't know if you both do that. The other thing I value with MIM, though, is I get that SPECT CT lung shunt, and I get that whole liver volume. So for me, the Mayo papers, I think, were very important in terms of percent liver treated when you're using ablative dosing. And so I really pay attention to whole liver volume and then my perfused volumes as well. But okay, great conversation. All right, Tyler, BSA versus MIRD versus Partition versus Voxel-Based. Educate me.
Thanks.
That's a 2-hour conversation forever. Yeah. All right. So
30 seconds. Give me the skinny.
BSA is antiquated. It's outdated. I think I think if we were to ask ChatGPT to tell us about it, I think ChatGPT would tell you that BSA is the simplest to use. It's the least accurate, and it's just for historical purposes. And we talked about this one time when we did a different podcast. BSA should go in the garbage. It shouldn't be used anymore because the inaccuracies associated with it are not like there's too many variables that are not trustworthy that you shouldn't really be utilizing it in practice with the tools we have today.
So we should not be using BSA at all in practice today.
I agree.
I agree with that. 100%.
And so
that is medical malpractice.
So it is, but it's
agreed.
People still do it.
Yeah. And it's still in the IFU.
Yeah, and so
for resin, I believe, right?
But
well, hopefully that will change.
Yeah, and I think I think most people that are practicing to the level that you guys are realize this, right? So BSA is based on body surface area. And then you calculate, relative perfused, or the area of total liver you intend to treat. There's a lot of estimates that don't make sense. It just needs to go in the garbage. MIRD dosimetry is unicompartment dosimetry. That means that when I infuse an activity, I assume 1-to-1 distribution within that perfused territory. We also know that that's not accurate, but it is more accurate than not knowing what the actual volume of tissue that you're treating is. So MIRD dosimetry relies on a calculated volume, which is then converted into mass. And that activity that you will wind up delivering to assume whatever target dose you want to achieve is assumed via a 1-to-1 distribution. Now, that is also not accurate, right? Because you might be dealing with an HCC that is hypervascular. You may be dealing with a cholangiocarcinoma that is hypovascular. So there's relative changes in perfusion. Now, then you get into the partition model, which recognizes that there will be variable perfusion within that territory. There will be areas that assume more flow and areas that assume less flow. Partition allows you to calculate that. So you can look at dose to tumor, dose to normal tissue within that perfused territory. And then you have voxel-based dosimetry, which takes it even further. And it recognizes that not only is there differences in perfusion to tumor and perfusion to normal, but within the tumor and also within the normal, but more importantly, within the tumor, that there will be variances in distribution of dose. So you can take it even further and say not only is the tumor going to get a dose 2 times or half as much as the perfused tissue dose, but there will be areas within the tumor that will get less or more dose depending on how it is. Partition and voxel-based dosimetry are reliant on a surrogate or some post-treatment imaging, right? So I wanted to highlight this, and just before I hand it over and let Nima, be critical of the way I'm describing it.
I'm learning, so this is
Before I hand it over, I will say, if you're going to do partition or voxel-based dosimetry, you have to recognize a few things. One, you have to use software to calculate it. And that software is only as good as the surrogate with which you use. And Nima has done a great job pointing this out. MAA is not the same as Y90. It doesn't have the same mass. It doesn't flow the same way. And depending on where your catheter is positioned, when you deliver your MAA, it will be entirely different than how you deliver your dose. Flow dynamics play a critical role in understanding partition and voxel-based dosimetry. Partition dosimetry, what I get frustrated with is when people pretend that they are doing partition dosimetry without software. You can't say that you have a T-to-N ratio of 3-to-1 unless your software tells you have a T-to-N ratio of 3-to-1,
It is
or
complete
6-to-1,
guess, right?
or 44-to-1, or whatever you want to make up. Software has to tell you that. So people that say, I do partition dosimetry, the next question I ask is, okay, cool, what software do you use? And, well, I don't have any. And I was like, well,
Then you're not doing
you're not really doing. You're guessing. And look, in all fairness, I just want us to be honest when we're talking about how we do things. And I think it's important that you have to say, like, you might be, in quotes, doing partition dosimetry, but you're really kind of guessing at the end of the day. And even then, MAA, you're still guessing too, right? So there are some inaccuracies on the pre-treatment side of things when you're doing partition and voxel-based, but that takes it to a next level. And there's more complexity with calculating those things. So for me, MIRD is the most simple form of dosimetry. I recognize that there will be variances in flow. Because the majority of my practice is heavy rad-seg, even in the metastatic world, I still rely on it because I think those variables, I'm okay to account for those variables within the rad-seg realm.
Before I turn it over to you, that was great, Tyler. I want to touch on it. So MAA in particular, right? I don't think it's I'm curious how you both feel. We'll get into this. I don't believe it's a one-to-one surrogate. There are clumping issues.
We don't have to believe, actually. People have published out there that it's not a one-to-one.
There's a lot of
literature.
So then that brings us to the topic of scout dose, which you have published on, and so there's a lot of interest there as well. I do want to point out, though, personalized dosimetry is partition and voxel. Both are considered personalized dosimetry, correct?
I actually disagree with
You do? Okay.
I think a MIRD model dosimetry for a radiation segmentectomy is personalized dosimetry. Because what are you doing? Tyler is going to do a cone beam CT. He's going to calculate the volume of the angiosome he's treating and the framework that he has in his mind. If the tumor is smaller or larger, he would say, okay, I want to deliver between 400 to 600 gray, assuming a uniform distribution to this angiosome volume, right? That is personalized to that patient's anatomy, the liver volume or tumor distribution, et cetera, et cetera. So I don't think partition or multi-compartment dosimetry or voxel-based dosimetry are necessarily the only personalized dosimetry.
I can get on board with that.
I actually like you. Juan says this all the time too. And so it's like I'm listening to my partner to say this. I agree with you. I think personalized dosimetry is personalized to the patient. It's taking in all the factors that it doesn't necessarily just have to be doing what we would call advanced dosimetry. But it's personalizing it to that patient. And so that I couldn't agree with you more.
Which is we're prescriptive to the patient, right? This is not one size fits all. We're not dumping 120 gray, 100 gray MIRD into the lobe of the liver.
So to kind of piggybacking, first of all, no disagreement with what you said in terms of the different dosimetry models. I think BSA needs to go. BSA and empiric dosimetries are both antiquated 100%. I think MIRD, again, for single compartment ablative dosimetry, and we can even extend that sometimes to radiation lobectomy, which we'll talk about later as well. It can definitely be done with a single compartment. Radiation lobectomy is a little bit more nuanced. Potentially, you would need partition or multi-compartment dosimetry. Between partition and voxel-based, I don't think we are there with voxel-based dosimetry at all in terms of prospective dosimetry with voxel-based, because that would definitely need a one-to-one surrogate. And we know for a fact MAA is not a one-to-one surrogate to Y90, because it becomes just too many inaccuracies. Basically, it's garbage in, garbage out data. Partition, while not the best, because of the differences between MAA and Y90, still for low bar treatment, where particularly in a palliative setting where we want to make sure we want to stay below a certain dose to the background liver, and people have looked at the discrepancies, including our own studies, of the dose to the background liver versus dose to the tumor predicted by MAA versus Y90, the eventual Y90. Luckily, while there is discrepancy with both of them, between the MAA and Y90, at least the discrepancy for the dose to the background liver is less. And that's where we think we should use partition, actually, most anyway. So I don't think we are there now to use voxel-based dosimetry for pre-treatment planning. It has a lot of value for post-treatment confirmatory dosimetry, which we'll talk about later. But I don't think you're gaining anything by doing voxel-based dosimetry prospectively at this point. Yeah,
I would agree with that as well. I mean, for me in my practice, voxel-based is post-rad-seg looking at my D95s. And your team has published on this as well. And the value of imaging response and then pathologic response related to some of those numbers, right? Which I know we'll get into. Okay, so real quick, I want to touch on this. High lung shunt, what precludes a patient from treatment? Is it lung shunt or lung dose?
Lung dose, and not only lung dose. This is one of the areas we need to highlight the differences between the two devices because of the number of particles.
Absolutely.
And there are published studies on these that radiation pneumonitis can, just like how we get complete response in HCCs with 300 gray as opposed to 1,000 gray or 600 gray with resin compared to glass because of higher number of particles, the biologic effect can be also toxicity that can happen at lower doses. So there's a systematic review that was published 4 or 5 months ago now on JVIR looking at all reported, again, we mentioned that all the reported radiation pneumonitis cases in the literature, they have inaccuracies because of the lung shunt fraction with the planar imaging used and the fact that almost all of them assumed a lung volume or lung mass of 1 kilogram, and all of those are inaccurate. But despite all of that, there are radiation pneumonitis reported at lower doses for resin compared to glass. All the glass ones, at least reported, are above 30 gray. The resin ones, there have been anything from 15 and up.
Well, and it's not just lung injury, also radioembolization-induced liver injury as well. The threshold dose for resin
for both
for background liver is lower than
the biologic effects as you go higher with the number of particles tend to happen at lower doses. The biological effect can be tumor response. It could also be toxicity. It could also be toxicity both to the liver and the lungs. Yes, 100%. So projected lung dose, not the lung shunt fraction.
Agree, disagree?
So I agree on the lung shunt stuff. I think the lung shunt is not a percent lung shunt is not a barrier to treatment. That said, a lot of high lung shunts result in a lot of high lung doses, which you got to be cognizant of. And so I tend to never go above 30 gray in a single session, and I try to stay below 50 gray lifetime. I have cheated. I've gotten very, very close to the line on both. I've probably eked over 50 gray in lifetime dose, and I've had patients do fine. That's not to say that that's necessarily the safest way to do it. There's a lot of discussion that happens on the front end and the back end with the patient, with the referring providers, if you're going to do those kind of things, because you got to understand that you're really kind of you're branching out here. In general guidance, I would say stay below 30 gray, really stay below 25 gray in a single session. Try not to ever get above that, and try to stay below 50 lifetime. You have to pay attention to what your doses are.
And keep track of them.
And keep track, right? And so that's where having good documentation in your imaging reports is critical. Some of the standardized reports are wonderful because we just go back and I reference what was my total lung dose there. So what's my cumulative lung dose now for patients that are going to need continual treatments? I think there's ways to mitigate lung shunt. I don't know if this is what you want to talk about right now.
That was my next question.
But
before you go there, I assume what you're talking about is the thresholds for glass. So what I would say
Lung dose,
for the lung dose,
Yeah.
projected lung dose. Based on what has been published recently, I would like to stay below 15 gray
For resin.
for resin because of those differences between the two devices.
Okay.
And I still haven't, it's hard to extrapolate the lifetime dose. Obviously below 50, but probably closer to below 30 gray. If you want to extrapolate,
Sure.
If it in a single session, it can happen at a 20 gray. And I've had cases that have gone above 20 gray with resin and nothing has happened, but definitely I've seen cases that has happened with less than 30 gray.
Well, the space has also changed, right? Pneumonitis from immunotherapy. A lot of these patients are on immunotherapy. I think that can kind of factor into this a little bit. So I have a little bit different spin. I tend to walk up to 20 gray single session. I tend to not go for glass. For resin, usually even lower than that, to your point. But I tried not to get all the way to 30 gray. And then if my lung shunt is high, and this is a little controversial, but I tend to minimize my particle count a little bit.
Yeah.
Right?
So I think to highlight the particle count thing real quick before we talk about the lung shunt, I think the reason sometimes why we see differences in, liver dose, lung dose is because I think you wind up with a higher particle load, you wind up getting more saturation of normal tissue, whether that be liver and lung. And if you have more saturation of normal tissue, more hepatic globules involved. I think that's why you see higher incidences of radiation-related injury because you have more complete coverage as opposed to more heterogeneous sphere distribution in normal tissue with a lower particle count. And that's not, you could pull off the same kind of thing with a higher specific activity resin dose too. You're lowering your relative particle load. So I think that kind of explains, at least that's the way that I understand it most why you see, normal dose thresholds with resin being lower than normal dose thresholds for glass because it's more lower.
It's a function of
the particle
distribution.
Yeah.
And so, I agree with you.
And so I think that's probably why you see it the way you see it. In terms of mitigating lung shunt, I think there's 3 ways to do it. And one of them I hate, and that's to do a low-dose Y90. The reason why I hate low-dose Y90 to fix a lung shunt is because you burn lung dose in the process of trying to fix a lung shunt. So you wind up eating what your cumulative lifetime lung dose would be trying to hopefully fix it. Most of the patients that have high lung shunts have pretty bad biology, tumor biology, and some have, I will say this, I expect when I see portal shunting, shunting into the portal vein, those are almost always associated with high lung shunt.
Sure.
I always see a lung shunt greater than at least 12%, often in the 20s. If I see early shunting or early filling of the hepatic vein, that does not always imply a high lung shunt. And so when people call me like, hey, I see early filling of the hepatic vein, should I shut this down? I'd be like, no, inject your MAA, test it out. And more often than not, I see lung shunts less than 10% when you see early filling, which seems counterintuitive. But that is associated with in my opinion, has not been associated with the higher lung shunt.
But it's vascularity. It's vascularity and not shunting, right?
Yes.
Which are two different
It's just,
animals, right? I'll also say on the portal vein side, it's different if you see, like if you're injecting or angiogram of the right liver and you see right portal vein versus you see reflux into the main portal vein.
Correct.
That's a different scenario as well.
Correct. Yeah. So low dose Y90, I think really kind of sucks. But a lot of these patients, for so many reasons, one, you're not really controlling the tumor. A lot of these are, the shunting is associated with bad tumor biology. And so you're not really controlling the tumor. So one, you're not really doing anything, you're burning a lung dose. Another option is to do TACE or do bland embolization. And I think there are many ways to skin this cat. I would like to give a definitive treatment, not a definitive, but to give a optimal treatment to the patient. So we treat with the intent to TACE as if we were treating it without Y90 on the backbone. So we use a smaller size particle to start. So we start with 1 to 3s and work our way up. Not as good as Y90. It's not going to be as effective. More often than not, there's going to certainly be some residual, but maybe the shunt comes down. And then we'll remap within a month of doing the bland.
How successful that has been?
Mixed.
Yeah.
But again, sometimes, and I will say sometimes these patients are just going to have bad biology and you just can't win. And that's where the next step is. So the next one is assuming the high lung shunt is associated with the patient with HCC. I think those patients benefit from a trial of immunotherapy. And I think you wind up going down one of 3 different pathways when it comes to immunotherapy. They get immunotherapy and they progress. And I think they were going to progress whether you did Y90, whether you did bland IMBO, or whether they got immunotherapy, or whether they got a lethal dose. They just have bad biology. You can't fix that.
Test of time.
Yes, and that's your test of time. There's going to be patients. So they were never going to win from the get-go. And so, unfortunately, there's no way to succeed there. There's 2 other options. One, they get immuno, they have a great response. Well, then most of the time the discussion becomes, from our oncologists, consolidate this for me, clean it up, knock it down. And then the third option, which is where I actually think the combination Y90 immunotherapy thing has really swung, is there'll be patients that get immunotherapy and they get disease control. They get stable disease, not disease response, but disease control. And so in those patients that get disease control, the lung shunt goes down, and you can almost flick these things with Y90. You don't even have to go you don't have to hit them with a gazillion gray of radiation. You can do 200, 300, 400, 600, whatever. You can treat those and the tumors respond and like they die. Yeah. And those patients, so there's 2 patients that stand to win in the immunotherapy game. So having tried all of those scenarios, if a patient has a high lung shunt, I really love them to try immunotherapy first.
So a couple of other points to add, all great points.
I also want you to hit, because of your collaborative relationship with RadOnc, is there a role for SBRT in this situation?
So there is a role for SBRT. One other procedure that I hate, but people have described and apparently it works, I've never tried it, is putting a balloon into the hepatic vein, which I don't know if you've ever done it.
No.
I thought it was just too much work, but people at Stanford have published on this. In terms of published data, what has worked and what has not on the TACE versus low-dose Y90, the biggest study that we have is out of Korea. They actually compared Y90 to CTACE, and they showed great reduction of lung shunt. That's why I asked you what kind of TACE do you do? They actually have shown great reduction of lung shunt fraction with CTACE, followed by Y90 versus the low-dose Y90. And I've tried low-dose Y90 and it doesn't work. So I think low-dose Y90 is out of the picture. I like the immunotherapy idea. I think SBRT definitely has a role, and CTACE. If they come across my desk now, I generally do CTACE.
You do CTACE, yeah. Okay. Do you feel like it affects, these are usually larger tumors, right? So does it affect your then mapping? You have a lot of lipidol in the area, or you don't feel that?
They're usually larger, so you don't go to the whole, so you don't CTACE them the way you generally do it as a definitive treatment. You do basically, I don't use particles at the end. If I do a CTACE and that's all I'm doing,
okay,
I would do the CTACE to stasis, and I use bland embo at the back end to kind of make sure it stays there. For these ones, I would use gel foam, and I don't do the whole 100 milligrams of doxorubicin with 2 vials of lipidol. I would do maybe 50, depending on the size.
I like the gel foam idea.
Yeah. I've done close to 10. We haven't published that data, but again, this is all based on what the Korean Seoul National, they have the most vast experience with that.
Yeah, well, and TACE will always have a role worldwide, right? Not everybody has access to Y90 from a regulatory standpoint, or just is comfortable with the device, right? Yeah. So TACE will always be available, and we get a lot of great data out of Asia from a TACE standpoint, specifically CTACE. Going back to your part about ballooning the hepatic vein.
Yeah, have you done that?
I have not. I'm curious, if you were going to do that, would you repeat the mapping with the balloons in place before you delivered a dose? I don't know that I would be comfortable just delivering a dose.
But I've always thought about it. If you balloon it,
What happens when you take the balloon?
Exactly.
And
are they not going to be behind the balloon with these beads or particles?
So then when you're delivering your Y90, your balloon's coming out hot, right? There are also concerns as you are trying to not have a particle spill in your room, that you need to really be cognizant of. So I mean, like, food for thought. So I don't like the balloon idea just because, and I wouldn't advocate that for people that tend to be I'm not very clean. Like I don't want to say that I create murder scenes in my cases, but I'm not clean by any means either. And so
sorry, I didn't mean to.
No, you're fine.
I think all these extreme measures we took, Many of them stem from the days of sorafenib as the only systemic therapy. I think with immunotherapy, we should kind of take a step back, as you said, and say, is this the only option available? And many times that is not. And even SBRT and external beam radiation at the time was not as robust the data as it is now. So there are other options. You don't have to feel like you're the hero here saving the day.
Well, I still think Y90 is the hero.
I know for like 90% of the time, but there is a good 10%, 15% that could be with other treatments,
And I'm strictly conjecturing here, maybe with the balloons in place, you're shutting down that intertumoral shunting and you get more particles. And so then into the tumor, and maybe the balloon's hot. But I don't know. I don't know if the balloon would be hot or not. I will make a quick comment. Tony Van Brooks, if he's listening, he's my mentor. When I was a fellow, he made a comment. I like to wipe my bloody hands on my gown, on my chest. And then I, go talk to the patient and see how they're doing. And he told me that you should never do that. That scares patients when you have blood on your chest. On there, right? So to your point about the emergency of the room. So anyway, let's do a quick case. Case 1, Nima, you want to take the lead?
Sure. So 62-year-old female with mast cirrhosis, 2.6 centimeter ACC, Child-Pugh A, ECOG 0, potential liver transplant candidate.
The only thing I would add, I always add ALB score. I always look at ALB score to help me subdivide Child-Pugh A patients. I don't know if you do as well.
So probably an ALB.
Probably an ALB1, I agree. But I do have Child-Pugh A ALB2 patients as well, right? So
I don't know about you, Tyler or Kavi. I hate this location. Every time I see this, I'm like, oh my goodness, this could be either a disaster with 500 feeders, or it could be a simple case with one or two feeders.
Right?
Yeah.
I had a mapping like this yesterday, and there were 3 feeders.
Yeah.
And so I feel your pain.
And even if you're a very avid ablator, I don't think this is the best ablation location. And as an institutional kind of approach, and this was more of a case at Emory than UNC, but we tend not to stick the liver percutaneously if they're a transplant candidate.
I think that's a reasonable consideration.
Yeah.
We didn't follow that. We treat with the way the BCLC algorithm worked. And so we actually would probably consider ablation here. Now, what we found with ablation, and I know that you've also reported on this, is that there are some times where you do ablation and you wind up getting some recurrences, and your recurrence rate is not negligible with ablation. So we looked at our Y90 versus ablation, or our Y90 versus TACE versus ablation data, and we actually found that there was a certain cohort of patients that got ablated in the sub 3 centimeter range that had a 2-year recurrence close to 30%. And so because of that, then it was in patients not with ALB scores or Child-Pugh scores, though that plays a role. It was specifically associated with the albumin. So if the albumin was less than 3.4, those patients only get Y90 referrals. And we're actually doing a trial where we're comparing Y90 versus ablation for patients that are hypoalbuminemic. So if the albumin was less than 3.4, we would Y90. If it was greater than 3.4, I think it's totally dealer's choice. I think microwave is a reasonable consideration here, but I wouldn't fault anybody for doing Y90, especially in a bridge to transplant candidate where you're worried about percutaneous access.
And I'm not showing you all the images. Well, the hepatic veins and the portal veins, if you actually looked at the whole cine, they would come very, very close. And obviously, all of us are fans of Y90. That's why we're here. But I've seen cases that you can knock out the whole hepatic vein or the portal vein with a microwave ablation.
Sure.
Not the main hepatic vein or the portal, but a major branch of it. And that's why, particularly in more central locations like this, I would map them. I'm not going to do a lobar treatment for a 2.5 centimeter tumor, but I would map them. And if I can reasonably select this and do a segmental or most bisegmental treatment, my preference would be Y90 here.
I think that's a very reasonable workflow. I mean, I'll add that I would also consider ablation here, especially if they didn't map well, for sure. But the first 5 years of my career, I had only ablation, right? So I would consider sub 3 centimeters. I would consider ablation here. But I think if you're going to ablate lesions like this in a location like this, proximity to the hilum is important, as you said. But then I believe that ablation confirmation software is standard of care. Like if you're not using confirmation software to get a margin, then you will for sure have recurrences.
And something that I have only recently started doing, after talking to many people, to me, cryoablation was a no-no in the liver.
But it works.
It works greatly. And actually, in kind of retrospect, now that I've done probably 20 cryoablation cases in the liver for something of this size, I would consider that as well as an option. I would actually, to be honest with you, feel more comfortable doing cryo here than a microwave.
I agree
What
with
do you
that.
think?
I totally agree with that. I think cryo, my practice is a little more cryo for METs and microwave for HCC, but I think something central like this is a cryo could be a little bit safer.
Yeah.
So I totally.
Do you use cryo at all?
I do. I used it recently on so it was a patient with a cystic artery feeder that was going to, obviously, if I were to Y9 it, I would have trashed the gallbladder. And it's like you couldn't isolate it enough to get away from not treating the gallbladder. I have microwaved on the gallbladder, and I have had an injury. I've put a microwave probe through the gallbladder, and the patient did totally fine. But if you microwave on the margin of the gallbladder and you're not paying attention to it, they can get cholecystitis. So you got to be careful with that. So I actually cryoed on the gallbladder. The patient did totally fine. And I started expanding cryo on the liver, not for big tumors. Like that's a decent cryo ice ball that you would need to put in for a 2.6 centimeter tumor, but smaller lesions and critical structures, I like cryo. I think it has a role.
Definitely. I think that needs to be emphasized, and hopefully, and actually, to my surprise, there's quite a bit of data published on cryo in the liver, in HCC and otherwise, which I was completely ignorant to.
The ones that I tend to stay away from are the coagulopathic patients, obviously, for obvious reason, right? So
yeah. So anyway, here obviously no surprises. We went for a Y90. I'm not showing you all the images. So we started with a more general cone beam of the whole liver, and then we did a more selective cone beam. And I think you kind of truncated some of the images.
I did.
Yes. Yeah. So there was a single feeder that we thought was supplying the tumor, and that turned out to be actually. So what I do is I do the cone beam, I do the angio initially, I do the cone beam, and then we go selective, exactly the same approach that Tyler uses. So we did you're showing the more selective cone beam, showing that there was complete coverage of the tumor and the segments involved.
And then MAA.
Yeah, so this is where I differ from Tyler in terms of how I calculate the volume. I actually use MIM for calculating my volume.
So you use SPECT?
I use SPECT. Yeah. And I give MAA segmentally.
So you give it from the area you would intend to treat.
Exactly. Yeah. And with the same microcatheter.
I understand. I will say this because we get this question asked a lot. And I think that this is you bring up a good point, and you have great results. So MAA, you have to be very particular about how you inject it because it does clump.
And how much you inject.
Yes, how much you inject. I'm going to get to that in a second. How it clumps.
Yeah.
And because I have seen it thrombose an artery. And in my experience, it was because I probably let a little bit of blood come back in the catheter. I didn't basically sandwich it with saline or contrast or anything else. And I didn't pay attention to whether or not it was clumped. I didn't dilute it out in saline. I injected it through a 3 cc syringe. So those kind of things. So for a RadSeg, because I'm not using situation different than yours, I draw my volumes off cone beam CT. So I'm not relying on my SPECT CT, which I don't disagree with using that. You just have to understand sometimes the MA will burn you if you're not careful. Yeah. But I tend to inject in RadSegs my MA from a low bar position. But I think if you're comfortable with what you're doing and you know how to control the MA and you're not.
So let me tell you what I do.
Keep going.
So generally you can get a 1 syringe of 4 millicurie MAA, or for segmental, I've actually changed our workflow. I ask for 2 millicuries of MAA. So they come in 2 syringes, 2 millicurie each. Doesn't matter whether I use 4 millicurie or 2 millicurie. I always dilute the volume that I get to 10 cc with saline. The reason I do that, one, is to prevent clumping, because you don't know when this MAA was drawn in nuclear medicine, how long it's been sitting on a shelf somewhere before you start using it.
To your point, my MAA is on the desk outside the room from 8 a.m. regardless of what time my case is going.
Exactly.
It sits all day long.
Yeah.
So I have this issue as well.
I used to get clumping before. Since 4 or 5 years ago, I changed to diluting it to 10 cc. I've never had clumping anymore.
Agitate at all?
No.
You don't
just
agitate?
One. So
you take it through a three-way.
Yeah,
so
three-way, and you inject it gently, the 10 cc, or you inject enough saline to make it 10 cc. When you do that, whether it is 2 millicurie total or 4 millicurie, then you know exactly how much of it you would be injecting. In a segmental situation, this very case, this is only 1 millicurie of MAA.
So you get
I don't give 4 millicurie of MAA, and that could be another reason you would get embolization. And particularly for my practice setting that I do the treatment the next day, I'm even more cognizant because you're going to bring them in 1 to 3 weeks to do the treatment. I'm bringing them the next day. MAA could be definitely there next day and has not, it could be a case that it hasn't kind of recanalized the vessel. So that's why you really want to make sure you do it a certain way. I like this, and I realize there's kind of a dichotomous way of doing it. Some people do it the way you're doing it, that you don't want to inject your MAA segmentally. I like to simulate as much as possible what I would be doing on the day of the treatment. But again, you have to know what you're doing in terms of the volume and the way you inject.
So one of the points that you just emphasized, you definitely take that millicurie dose down, or that MAA dose down, right? You're doing 1 as opposed to 4 or 5.
Yeah. This is 1.
Yes, and I think that's important, right?
Yeah.
I think people, if they're going to consider doing something like this, it's not a 5 millicurie thing.
What do you do?
So
Segmental or low bar?
I do a little bit more low bar. I don't think it's wrong to do segmental as well. If you drop the dose, to your point, we both worked at Emory together. This was normal for us. We calculate off the SPECT CT. I'll bring this up. I know we have data that is slowly growing in this space. Properly selected patient, meaning no tumor thrombus, no tips, sub 3 centimeter lesion. Do you even need the MAA?
No.
Oh, I don't think you need it to calculate a lung shunt fraction. I think if you use your MAA to calculate your perfused volume,
Sure.
if you're going to...
So we have treated about 30 patients so far as a single session.
I would not skip the mapping on this patient, because a patient with a tumor situated centrally in segment A could have multiple feeders.
Mapping is different than MAA. That's the thing that we have to...
But you're about to get into I think you're getting into the no map treat.
So I can tell you at least how we do it. When we say single session in our institution, we actually book them for a longer period because you have no idea what you're going to see with the anatomy, right? So you have to do many cone beams to figure out what the feeders are and calculate your volume of the perfused area based on your cone beam. That is when I do, because we don't inject the MAA. Those are so basically UNOS T1 and T2, this is based on Northwestern data. They looked at 1,000 plus patients retrospectively, and they showed that if they were smaller than 5 centimeter, with no tips in place or no macrovascular invasion, none of them had a lung shunt fraction of greater than 20%. In fact, the maximum lung shunt fraction was 14% in them. So yes, do we even need it? So I think people use mapping interchangeably with MAA injection. I think mapping is actually mostly the cone beam. MAA injection is for lung shunt fraction calculation.
I don't think you need a lung shunt. I would say this in
that's where
a
I'm
simple
going.
rat seg, I don't think you need a lung shunt.
And there's also now UCSD. UCSD has a publication on this topic, right? And there's data out of Asia as well on this topic. So we're really moving towards no MAA for some of these studies. But to both of your points, this is a more central lesion, so you do need to map the lesion and understand.
I wouldn't go in there with the understanding that this is going to be a single vessel feeder.
I honestly, even though this would fit a UNOS T1 or T2, this is not a case I would go as a same day map and a single session treatment.
The peripheral ones, though, you can start.
So we just published our data, and it actually has economical benefit as well, and it significantly shortens the time to treatment when you actually go with the single session. Hopefully we can talk about that more. But in a case like this, you would expect the lung shunt fraction to be negligible.
100%. It's probably 5 or 6.
So it was 1.
Not even. 1. There you go.
So this is with cone beam CT, with SPECT CT data, but on the planar it was like 1.5%, something like that. And I get my it says tumor volume here, but
that's your perfused.
It's actually the perfused volume, which was 242 cc.
And then the whole liver volume is 2,300. So you're taking less than 10% of the liver volume, right?
So this is where you need to know the differences between the two devices, right? So in a situation like this size tumor, what would you use for your dose to the segment?
So I'll probably be shooting somewhere around 600 gray to the perfused territory. I think that's kind of, I think the floor based on legacy data is for anything greater than 400. I think we're going to find new information. We have a multi-center rad path study that we're probably going to be publishing very soon that will show some other optimized criteria. For me, I tend to be, the tumor occupies a relatively small volume of the perfused territory, but I still like that 500, 600 gray floor to the perfused territory, especially when I'm treating less than 10% of the total liver.
Yeah.
So it'd be 600 gray. I prefer high activity spheres. Yeah. Like, so I'm a week 1 Friday kind of guy, which is right around 1200 becquerel per sphere. I will deviate anywhere from 1400 to 570 becquerel per sphere. So that's anywhere from a week 1 Thursday to a week 2 Monday for a rad seg like this. But I prefer my rad segs to be on the week 1 side of things. So late Friday, Thursday kind of thing.
So we published on the flex data, and we show that you get complete response with 330 gray. Yeah. So based on that, the way I've extrapolated, and that was with 3-day pre-cal. Yeah. I do 300 gray to the segment. Okay. And this was a 4-day pre-cal case, but since 5-day has come out, and this Cancer Y90 has the 6-day data as well, and 6 and 7 are going to come out as well. I use a 5-day pre-cal. I now, for a case like this, I would use a 5-day, but in this particular case, 5-day was not available at that time. So we used a 4-day pre-cal, obviously smaller or lower specific activity compared to a first week, or this would be like towards the end of the calibration for glass.
Yes, but again, I think you're emphasizing the point of you want to use, you're doing an ablative rad seg. Yes. You're trying to use hotter spheres.
Yes, for sure.
Regardless of what product you use. You're trying
there
to
are different thresholds because of the different, you can see that the number of microspheres are significantly different than what you would.
Again, I think Flex 5, Flex 6, Flex 7, those, if you're a resin guy and you're trying to optimize.
This is not a case of a day of calibration.
Yes.
Or a 1-day pre-cal or a 2-day pre-cal. You need to go, if you want to use resin, go with the hottest ones that are available within your institution.
And I think that
and at lowest number of particles, because again, the real estate is limited here.
Mm-hmm. Exactly.
So you have to kind of know the confines of what you're dealing with,
From a glass standpoint, I'm completely aligned with everything that you said. On the resin side, I tend to more 4 and 5-day pre-cal, and I target 400.
Yeah, and you can do 400 as well.
Yeah. And I don't get to.
And this is a discussion that we always have in all the Y90 courses. Is there ever a too much dose or too high of a dose? I don't know.
Yeah.
I don't know whether there is one. I mean, maybe the patients become more symptomatic if you give 2,000 gray into a segment versus 600 gray to the segment. But there are some people that are a fan of 1,000 gray to the segment.
I personally find with very, very hot doses, I get more symptoms. But I also find that with high particle counts. So if I give a ton of particles into a segment, I can guarantee that patient at 4 or 5 weeks is going to be like, man, I was miserable. But same thing, if I give a hot dose, especially if it's like a dome lesion or a segment 2 lesion, they will 100% will feel that.
Radioembolization syndrome.
Yes. So we've used 300. It's worked for us. And we're still doing 300. Having said that, once 6 and 7 come, I'm probably going to increase this to 400. Because you have to kind of, as they are becoming more available with our resin or Sirtex is coming out with more pre-calibrated doses, it is coming more towards the earlier 2nd week glass.
Well, the two products are meeting in the middle, right?
Yeah. So and we need data like what you're suggesting, both on the glass and resin side in terms of what is the true intersect between particle density and the specific activity. We don't know that fully yet. Yeah. But we need it for both devices, Well,
just for the sake of discussion, the glass number has changed recently, right? So at day of calibration for glass,
it's 4,000 becquerel per sphere. It's actually like it's closer to 4,200, but it's easiest to remember it as 4,000 becquerel per sphere. When it comes out of the whatever the reactor is, it's 4,000 becquerel per sphere at noon on Sunday. And then you can do your decays a week 1 Friday at noon, which is, I guess, 5 days post-cal, is 1,200 or 1,175 becquerel per sphere.
Okay.
Yeah, and then Wednesday, I think Wednesday at noon is right around 1,800 becquerel per sphere.
First week.
First week.
Like 3 days.
So
post.
is there
Yeah.
anything in your practice that you think may be too hot and too few particles? Like a Wednesday or a Tuesday or a first week?
I had great responses with week 1 Tuesday.
I know.
but
I don't know. I'm
it's,
just trying to figure.
it's-
But great response with hotter doses?
No, this might deviate way too far than you wanted to for a case discussion. But I don't treat week 1 Monday, so maybe there. But again, I think if you are dosing at 600 gray to a perfused territory on a week 2 Tuesday, I think there is a minimum particle density you want to achieve. You're probably achieving that with a week 2 Tuesday. I'm sorry, week 1 Tuesday, you're probably achieving that if you're targeting like 600, 800 gray. That said, that's like depending on what kind of your perfused volume is, there's some nuances to it.
Yeah.
I like the dosimetry guidelines for glass, when you're doing rad-seg, encourage you to treat week 1 Wednesday to week 2 Tuesday.
Yeah.
Bo's team has come up with some great stuff in this multi-center rad path thing, which eventually will come out, has highlighted you want to treat within 8 days post-cal, which is week 2 Monday or earlier. And that's 570 becquerel per sphere or earlier.
When you said earlier, you're really trying to treat week 1 Thursday to week 2 Monday, right?
That's
And
really
it's-
my
yeah,
window.
Yeah.
That's the window I like. But, I think if you are doing something and you're getting great outcomes and you're tracking your patients and you're working within the confines of what you're working with and you have stuff that works for you, hell yeah. Patients stand to benefit. And I think we all recognize that high activity spheres are playing a better role in rad-seg.
Yeah.
Rad-seg.
And that's precisely why I think Sirtex is creating those 6 and 7 day pre-count.
Which we're all very excited about. Real quick, so 4,000 becquerel per sphere, slightly above that, and 250,000 particles per GBQ.
Correct.
Right? That's
If you want to try to calculate out what
the
your
glass numbers, right? So because the calculator is wrong on that note. So
on for the cancer one.
cancer one,
because it's still the
old number.
older calibrate for Therasphere. For Therasphere, it's accurate. Yeah.
And if and when there is a second calibration date for glass as well, then I think this hopefully will simplify some of these conversations as well. So this is what you got post-delivery, right?
Yeah. So Tyler made a brief kind of discussion about this during the Voxel-Based dosimetry. We did, again, you can get reimbursed for this if you do the coding properly and all of that. You
Two codes, 77295, 7300.
Yeah, you have to be authorized user for it, etc., which is a different discussion. But so the mean tumor dose here that was delivered was 506 gray. But what I'm actually paying more attention to is the minimum tumor dose.
Okay.
And it was 140 gray or 138 gray. And based on the rad-onc data, when they do a SBRT for an HCC, they aim for 80 to 100 gray. But we know that they're radiation
normal,
all homogeneous. They don't have the heterogeneity that we have. So I use this minimum tumor dose as a safety check at the end, and I want to be above 100 gray. Okay. At least on the resin cases. I'm curious to know what Tyler thinks on the glass side of things. If I'm above 100 gray, I feel comforted that probably the tumor was covered adequately using the resin calibration that I use. And most likely we're going to get complete response.
And this to me is the value of voxel-based dosimetry, is post-180 dosimetry. I think we talked a little bit about post-MAA voxel-based dosimetry, but here is the real value for post-190 voxel-based dosimetry. Tyler, what numbers are you using?
So you're referencing the D99 or the D95.
Yeah,
right?
the minimal tumor dose, which is D90.
The 1 percentile dose. And so Zach and our group and the UCSD group have both kind of come up with, the higher your D95, the better your response rates and your durable response rates are.
Because of the error around D99.
Yes, well, and we use D99 in ours, and I think you published on D99 too. So D99 is a tricky one to draw, and it really matters on how you register all your information. At the end of the day, Y90 works because it generates critical hits in structures, right? And the more your dose, higher dose results in more it implies more activity in the most cold air or in the D99. So if you get a higher dose in your D99, it just means you have more critical hits in that D99. So at the end of the day, to your point, you just want to optimize as many critical hits in the coldest area of the tumor as possible. And that's what's going to give you your most durable or best response. And so Ours, we've had, and you can't control for this. It's not like, this is just telling you on the back end that what happened. And that's, it's a confirmatory thing for you. We have found that when we got doses closer to 800 gray in the D99, we had better responses than we had when we got 200 gray in the D99. And at the end of the day, there were 4 times as many critical hits in the D99 in those tumors than there was in the ones at 200. Doesn't mean that the ones that got 200 had a bad response. It was just that you had a higher likelihood of having a favorable response when you had higher doses. And it just implies it's a statistics game. And so I'm just doing what I can to get better statistics and better hits.
So to get a D99 of 800 gray, what was your mean tumor dose?
They're closer to 1,000, right? But again, those you see those in small tumors, right? Where there's more homogeneity associated with the dose. And the 3 centimeter, when we get into the 4 centimeter and greater, there's a lot of heterogeneous dose distribution. At the end of the day, the tumors that are big, that the D95 in those tumors, when it's higher, they do better.
Of course. I mean, at the end of the day, radiation...
it's unbiased, right? And it does what it needs to do. But I think you are highlighting the most important point. The goal is to get as many critical hits into the coldest area as possible. And whatever it takes for you to do that is what is going to get you your best result possible.
Well, and this goes back to volume of tumor to volume of perfused. Angiosome, right? So
that's a deep dive.
It is, but like that's where you see super hot tumor doses.
Because though it's 400 gray to the perfused, when the tumor occupies a very small volume, there's some different games to play in that red zone.
Real quick, define D95 and D99.
So D95 is the minimum dose to 95% of the tumor. D99 is the minimum dose to 99% of the tumor. And so you see that DVH curve that Nima has, it's the blue arrow, or it's the blue S-shaped line. And so the dose, the percent dose, you can see, I don't know what it's called, I can't read it from there, but it's percent. At close to 100, you can see that the dose travels along the x-axis. And so at the top part of it, that is going to be where those two intersect. That's going to be his D99 or D95. And he got a great dose in there, right? I mean, like the patient did incredibly well, I imagine. So that's where DVH curves come into play. And that's voxel-based dosimetry. And again, it's a confirmatory thing.
Mm-hmm.
We use it to kind of answer questions on the research or academic side. We're not doing this
Have you ever, so let me ask you this. So recently I had a case that for whatever reason, part of the tumor was colder. It didn't get adequate dose and it correlated. What I did was, instead of, what is your usual follow-up? Do you do 8 weeks?
Everyone gets 1 month.
Yeah, that's right.
1 month. Okay. So we don't do a month. We do generally 3 months or 2 months. But for the ones that I'm more worried about, I get a 6 weeks. And that one, based on the post Y90 dosimetry, I thought that we didn't deliver adequate dose to a portion of it. And lo and behold, that portion is still viable. So I'm bringing her back.
Sometimes it's a missed feeder. Sometimes it's a vessel. There was preferential flow into one or the other.
Yeah.
More often than not, we find that it's more often a missed feeder in smaller tumors.
Yeah.
Larger tumors, there's a lot.
This was actually a tumor. I mean, based on the cone-beam CT, it seems like it was covered. But again, that's where the discrepancy between MAA, contrast, and Y90 particles are, So.
But to your point, it is a confirmatory. I think. I think it is helpful. The numbers are emerging in terms of how we're utilizing them. I want to highlight one thing you said earlier: minimum dose compared to maximum dose. That is a thing in the radiation oncology literature.
Yeah.
Heterogeneity index, right? We haven't really tied that. I don't want to go down. This is a whole nother deep dive, but we haven't really tied that, at least in my knowledge, to the Y90 world. So,
they have not.
There is a role there. But then this was your result, right?
Yeah.
Beautiful, and I imagine it kept looking like that.
Yeah, I mean, she's been listed for transplant. Hopefully, we'll get the post CPN analysis as well. Yeah.
Well, I think that's a key. If I have a patient that's actively listed for transplant and is in ALB3, Child-Pugh B8, are you going to go after this? Actively listed for transplant. Agreed. 100%.
If you don't go after it, it's going to progress out, and they're either going to not be a transplant candidate, they'll die of their cancer, they have transplant as a backbone. I think
100%. You got to be aggressive.
You can be. It's a good discussion.
Yeah.
With the patient and with your team.
But this had great odds, so yeah, agreed. And then you got to say it for me.
Oh, black hole of death.
Black hole of death.
Yeah.
Okay, all right. We're done. Thank you.
Thank you guys so much for tuning in. If you haven't already, please be sure to subscribe, follow, and rate the show. Let us know how we're doing and what we can do to improve it. We work really hard at making this a valuable resource for you, and we want to continue to do that. So give us your feedback. Lastly, tell a colleague about the show. We think they'll like it. If you have any questions or comments, direct message us at _BackTable on Instagram, LinkedIn, X, TikTok, and Blue Sky. BackTable is hosted and produced by myself, Chris Beck, and co-hosts
Ali Behetti,
Michael Barraza, Sabine Dond,
and Aaron Fritz.
Our production team is led by Kieran Yannon,
Aaron Bowles,
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang, Manisha Naganathanahali,
and Manbir Singh Sandow.
Administrative support provided by Judy Dela Cruz.
Thanks again and see you next time.